That baby survived and is neurologically intact.
Wow.
Actually, got the Guinness record.
Wow. Yeah.
The most immature baby in the world.
Giving the trainees all those NICU secrets, teaching the families, bringing you physiology and the latest evidence in management of NICU babies. Just having fun with it.
Well, everybody, we have a super special guest today for the 20-minute with an expert. We have Dr. Waldermar Carlo. Everybody knows his name, but of course, we're going to go ahead and introduce him. Dr. Waldermar Carlo, thank you again for joining us again on this 20 minutes with an expert. For those who don't know him, let me do a brief introduction. Dr. Waldermar Carlo is the co-division director and Edwin M. Dixon Endowed Chair of Neonatology at the University of Alabama at Birmingham. He has also not only been involved in single and multicenter randomized controlled trials, both nationally and internationally renowned, but here today he is here as an expert for, we're going to touch on the topic of extremely low birth weight mechanical ventilation management. So thank you very much again, Wally Carlo, for joining us today.
Thank you, Prem. Thanks a lot for the opportunity to share some thoughts with so many people.
Okay, thank you. Well, let's go ahead and get straight to the topic. And I have a few questions prepared for you, so let's get to it. So we'd really like to know your management and strategies. When we have a patient, for example, an extremely low birth weight infant that is on CPAP, that you have given surfactant that may be on, that we have a low oxygen level of CPAP, maybe let's say 30% FiO2, what would be your strategy? Would you rather increase settings on that CPAP, maybe go to NIV, continue to increase settings, or would you consider giving surfactant early on this baby? Intubate, give surfactant, or would you increase your settings? What would be your strategy on this baby who is extremely low birth weight?
That's a great question, a very important one, and one that we have some evidence, but not yet all the evidence. So let's take the evidence from the support trial and the Vermont-Oxford network trials. Those are probably the best two trials that inform us on what to do. And by design, what they use is a FiO2 of 40 or 50% or more to say that the patient should be intubated and given surfactant. So that's the, maybe I would say, the highest level of evidence. But what we don't know is if earlier use of surfactant would be better. So for example, in some institutions, they use 30% as the cutoff. So being on CPAP and more than 30% has been used. And that's a question that needs to be really tested to see if earlier surfactant would be beneficial. Then I also use a few other facts that have not been used in the literature, but we know may influence. So for example, on the smallest babies, we know that at least surfactant, the second dose is beneficial at a lower FiO2. So maybe the first dose would also be beneficial at a lower FiO2. Whereas, let's say a bigger baby in the range that we're talking about, extremely low birth weight infant, but on the older side, more mature, who was exposed to antenatal steroids. So maybe I would aim for a higher FiO2 threshold, such as 50% or so.
That's interesting. Okay, so it'd be interesting to maybe use the extrapolation data from the support trial, and as you mentioned, but maybe have two groups, the smaller group versus the older group. That's a very interesting way of putting it. I like that. Thank you very much for your answer. So jumping to the another question. Do you have a preference? And I know this is always very difficult, but do you have a preference of pressure versus volume modes for these extreme preemies? And what are your thoughts? Why do you like one or the other? I know it's a tough question.
And that's a really good question also. The meta-analysis shows that volume ventilation may be superior, okay? So that's the evidence. But I think it also depends on how ventilation is done. So in some centers, when they use volume ventilation, they're also using very high rates because they use the ventilator to trigger, and then the patient is breathing faster than 60 or 70 or 80, and is getting volume supported breath at that rate. Whereas when they do ventilation with pressure, they may be using a low rate. In analysis of multiple databases, the usual practice in a lot of neonatal ICUs is a rate that is low, like 30 to 40. Mm-hmm. But there's a meta-analysis that is quite interesting. It's hard to find, but it's in the Cochrane database. And it's a meta-analysis of using a high rate with conventional ventilation of 60 or more versus the usual 30 or 40 or so. And a rate of 60 or more leads to less air leaks. So that's a benefit, and actually a better survival also. So that's a practice that I tend to use. In these babies, I put them on a higher rate, typically related to the baby's spontaneous respiratory rate. So whether I'm doing pressure ventilation or volume ventilation, I'm using a rate that approximates the baby's own respiratory rate. And when I've talked with my friends who like a lot of volume ventilation, they say, well, if you do it that way, then volume ventilation would not be advantageous over that way to do pressure ventilation. So I think that's an issue. That if you're doing pressure ventilation, make sure you're using high rates such as those that you're using with volume ventilation. And the final comment that I have about that is know that if you're using a pneumotachographer online or inline when doing volume ventilation, so you get good accurate measurements of volume, you're also adding dead space. Yes. And while the manufacturers may say, oh, it's only 1 cc of dead space, know that for a 500-gram baby, that's 2 cc's, which is a pretty large volume, given that if you're trying to ventilate it with a total volume of 4 to 6 cc's per kilo, that will add 2 cc's per kilo to that.
Folks, that's coming from an expert. That's really important tips, something that most people don't tell you. So keep in mind, that's really important. Thank you, Wally, for that information. That's great information. Okay, let's move on to the next question. What are your thoughts of prophylactic, and we're going to get to now high frequency, whether we use prophylactic or whether you use prophylactic use, meaning do we jump straight to the use of high frequency, whether you use oscillatory or jet ventilation? High frequency immediately for extremely preterm infants, or do you use high frequency as a rescue ventilator? What's your strategy for these extremely preterm infants?
So if you look at the overwhelming majority of data, it would say that high frequency ventilation tended to be better as, let's say, prophylactic or early, when they establish RDS and you use it early. But if you look individually at the studies, the patients in the studies that show no benefit, the babies in the control group, meaning conventional ventilation, had good outcomes above the expected outcomes for that gestational age or birth weight. In contrast, in the studies with high frequency ventilation, that show large benefits of high frequency ventilation, the control group had really bad outcomes overall, worse than expected. So I think it's an interesting issue that if you're getting good results with conventional ventilation, you may want to delay high frequency ventilation more towards rescue effort. But if you are not having good results with conventional ventilation, maybe earlier high frequency ventilation would be better. And I think, and then in terms of oscillation versus jet ventilation, I think it's difficult to know which one is better because there's not really a head-to-head comparison. But also, there's a good reason why not being there have been studies on head-to-head comparison, because these are two very different ventilators and you have to develop expertise. So I usually, when people have consulted me about which one to use, I either ask them for what do you have already, or what do your physicians and therapists have expertise with, to try to focus on that and keep improving the expertise. We have both, and frequently a baby is failing oscillation and it goes to jet ventilation, and vice versa. And interestingly, in the randomized controlled trials of high frequency versus conventional ventilation, there was a lot of failure high frequency ventilation also, and a lot of crossover. In fact, in one of the largest trials, the NIH trial, there was more failure with high frequency oscillation than with conventional ventilation. And improvement on the other alternative mode. So it's interesting. So I think we still have to learn more how to use the high frequency ventilators better. And I think there's opportunities to keep improving.
Yeah, sometimes, like as you mentioned, sometimes if you have a unit that's very well versed with one ventilator, it might be more dangerous to try and force, the whole unit to try and change their practice. So you bring up some very good points. Okay, last question. Do you think we have reached the lower limits? I know in some units, and in particular in your unit, do you think we have reached the lower limit at 21 weeks of survivability, or do you think we will reach one point where we can go lower than 21 weeks? What are your thoughts?
That's a really good question. And you were here where we were struggling with whether we take care of 22 weekers, and we gradually got into it, and depending on parental preferences, we provide care at 22 weeks pretty routinely. We don't provide care routinely at 21 weeks, but we recently sent home a baby who was born at 21 weeks and 1 day.
Wow.
Confirmed with early prenatal care and early ultrasound and dates that were consistent. So we were quite clear. But this mother wanted everything to be done. And I had to support my attending. When I came in the morning, the attending immediately told me, look, this happened, and I don't want you to get angry with me, but this is what happened. And I was put in a position that I had to support the baby. And I understand, because at that time, you're questioning yourself, is it really good dates? Could the dates be a little bit off maybe, and this baby is more mature? So that baby survived and is neurologically intact.
Wow.
actually got the Guinness record.
Wow. Yeah.
The most immature baby in the world.
Incredible. Wow. Well, congratulations to your team for all the efforts. I know that involved the whole team, including, I know, nurses, nurse practitioners, RTs, and everybody.
It's a big team, and the team was very supportive of the effort because the mother was very clear that she wanted everything to be done, and she had taken good prenatal care. She had done everything right, but she just delivered prematurely. So regarding the question of what's going to be the lowest limit of viability, I think it will depend, but I think there are technological limitations that may be overcome. As you may know, there's some efforts to use an artificial placenta, in quotation mark, artificial placenta, to support the baby after birth with circulation. So that's a possibility. I worked with this in the 80s, trying to develop a little ECMO circuit that could be used for gas exchange through the umbilicus.
Wow.
So it was effective. We actually, to make it work, we were perfusing parts of the brain.
Wow.
That's how we designed it. It was some research that we were doing. But we knew it could be used to perfuse the whole baby.
Wow.
So there have been a lot of advances, and in the US as well as in Europe, there are efforts to support babies in this way if they're being born extremely premature. There's a lot of ethical issues, obviously. How much effort do you put in a single baby? What's the cost? What's the societal implications of this? I know those groups of researchers include a heavy involvement by society, parents. So it's being done in a very thoughtful way, but I think it will take years for that to come. But let me highlight, because I guess I've been around for a while. In the 70s, I remember being told, this baby is extremely low birth weight or extremely low gestational age. So most likely we die in the delivery room. So don't feel bad if that happens. But I also remember how there was not a lot of evidence of how to do resuscitation, for example. And resuscitation was practiced a lot with adult type of resuscitation with many medications and little emphasis on ventilation. So at that time, yes, it was true. The baby had more than 50% chance of dying in the delivery room. And then a pretty high risk of dying in the neonatal ICU. So now, 40 years later, we've made so much progress. Most of the extremely low birth weight babies do not die in the delivery room. The overwhelming majority survive the delivery room. And then obviously some of them die in the neonatal ICU. But we keep working, and I mean neonatologists and co-workers all over the world keep working to improve the outcomes of these babies.
I love it. Wally Carlo, thank you so much for your time, for your expertise. For everybody out there, this has been an absolute special treat. I am going to go ahead and put at the bottom in the comment section, in the description, I'm going to go ahead and put some of the trials. We talked about the support trials and the Cochrane. I'm going to go ahead and add those links for you guys to follow some of the trials that Dr. Wally Carlo has mentioned. Thank you again, Dr. Carlo, for all your time, your expertise. We really appreciate it. And we will be following up with the next 20 Minute with an expert very soon. Thank you again. And please, if you haven't done so already, subscribe to my channel. And if you have any comments for Dr. Wally Carlo, for myself, please add them in the comment section. Thank you, and we'll see you with the next video. See ya.